For the EVA talk, um, we all need to be motivated coming to the talk. I'll make it short. What drives me, the source of motivation, and self-improvement. Well, coming to the Maslow's hierarchy of needs, what motivates us are the roti, kapda, and makan, the physiological needs. Then coming to the love and belonging, the self-esteem, and self-actualization. The motivation could be intrinsic as well as extrinsic. The extrinsic could be satisfaction from an approval from others, while intrinsic is from completing the activity itself. Now, what are the behaviors which lead to self-actualization? So may I have a show of hands of how many people think that they have, self-actualized, they've achieved self-actualization? Well, very few. I think it is a process of achieving. It is a process as per the full potential. Listening to your own feelings and evaluating experiences instead of the voice of tradition, authority, or majority. Being prepared to be unpopular. Like we are in the land of Akla Cholore. So let's go Akla. But be prepared if your views do not coincide with that of the majority. Avoiding pretense, game playing, be honest, experience life like a child. How many of us do laugh out aloud? That is very important. Take responsibility, work hard, try to identify your defenses. Ask yourself, what did I do new this year? Try doing different things. And these people have a liking for peak experiences. Well, coming to peak experiences, well, I have dived air driving, I have wore wings and maybe dived from a cliff, sat on a chicken nest, or wrapped cobra, or watched international matches. Well, again, have been interviewed on CNBC National Live TV, and have, for the Times of India, I have spoken on a Principals Conclave. Well, so all this is my self-motivation or the liking for peak events. Coming to what is our, what motivates us? Well, stop procrastinating, because we have to step out of our comfort zone, and we should not also be entering the zone of exhaustion. So that minimum, that balance is very important. Now, the biggest wall you ever got to climb is the one you build within your mind. So take one step at a time. You do not need to see the entire path or the epics. So again, as Mr. Subhash Chandra Bose says, life loses half its interest if there is no struggle, if there are no risks to be taken, and jo dar gaya, wo mar gaya. Well, make mistakes and be ready to correct those mistakes, and be ready to hold the erasers. And again, coming to hurt, we all get hurt, but we have two options, either to keep suffering or to channelize and become wiser. And as Eva's, a queen will always turn pain into power. Again, a quote very close to my heart is, I kept going because I had no other choice. It was either fall or fly. And that's the story of how I got my wings. Take care of your mental, physical health. Energize from the nature, the sun and the moon. Exercise, laugh and medicate. On the right is definitely my photograph. Well, again, begin each day by looking in the mirror and say, I love you. Because self-love is the true to happiness, the key to happiness. Wear your smile, your confidence, and dress to kill. Impress and charm yourself first. Evolve and adapt. One reason why people resist change is because they focus on what they have to give up instead of what they have to gain. Surround yourself with the people who talk about visions and ideas and not other people. Choose your company wisely. Work on your 360-degree skill set, because 85% of your financial success is because of your personality and your ability to communicate, negotiate, and lead. Money. How many of us think money is good? Yes. Definitely. Money is like Dettol. It's a very important resource, kills 99% of your problems. But a sure sign of spiritual growth is when you want more meaningful experiences and less stuff. Count your blessings, practice gratitude, manifestation, affirmation. Repeat to yourself, I am going to make a beautiful life for myself. I deserve it. And to sum it up, I would request everyone to take out your selfie camera and take a selfie. Can I see everyone holding up your mobile and taking a selfie here? Yes, I can see Shuchindadi doing that. Oh. Well, if you're looking for that one person who will change your life, open your selfie camera on your phone. Thank you, everyone. With that, I call upon the glaucoma chairperson, the glaucoma moderators, to please start the glaucoma session.
Good morning, and that is a very well and motivational talk indeed, Dr. Swati. Now, to start with the glaucoma session, I'd like to call our chairperson, Dr. Shuchanda Shah. Shuchandadi, once you're finished with your selfie, please come front. Shuchandadi, Senior Glaucoma Consultant, Disha Eye Hospital. Next, I would like to call our panelists, Dr. Dipanjan Pal. Dipanjan, please come forward. Dr. Dipanjan is a senior glaucoma. Kothay galo Dipanjan? Okay. He is a senior glaucoma consultant, Disha Eye Hospital. Shuchanda di edike asho na. Dr. Manish Singh, senior glaucoma consultant, Netralayam, and Dr. Niloy Mojumdar, glaucoma consultant, Shusruta Eye Hospital. And here comes Dr. Alokesh Ganguly. Dot on time. I was searching for you. Very punctual. He's glaucoma consultant in Priyangvada Birla Institute. I would like to call my co-moderator, Dr. Tanya Roy Bhadra. Tanya, please come front. Now, gone are the days of only trabeculectomy as glaucoma surgical procedures. Now, we have an array of options, including the aqueous drainage devices, the MIGS, and others. And also, we would like to highlight in this session some tips about the treatment of glaucoma, what to choose and when to choose or when to switch and all that. And of course, Dr. Chandni will throw some light on management of pediatric glaucoma. So I would like to start with Dr. Shudipta Ghosh. Shudipta Ghosh works in R.N. Tagore Hospital.
Good morning, everybody. It's a pleasure to be amongst all of you. Today I'm going to speak on the management of tube exposure. We as glaucoma surgeons definitely have put our hands into glaucoma drainage devices, and we definitely should know how to manage a patient with a tube exposure. So tube erosion through the conjunctiva is an important long-term complication of GDDs, carrying the potential risk of infection and vision loss. After GDD implantation, the surgical site should be inspected carefully at all follow-up visits. This is very important, with particular attention to the thinning of the overlying conjunctiva. Fortunately, tube erosion is uncommon. Exposure occurs most frequently along the length of the tube, but the plate itself may also become exposed. Now, coming to the certain factors, however, can increase the overall risk of erosion includes the history of ocular inflammation, a high number of preoperative topical medications, neovascular glaucoma, prior conjunctival surgery, diabetes mellitus, and inferiorly implanted tubes. The surgical technique and tissue manipulations during GDD implantation can also influence the subsequent risk of tube exposure. Tension on the conjunctiva after primary peritomy closure can cause dehiscence or conjunctival retraction in the postoperative period and lead to early tube exposure. Furthermore, the location and the angle of the tube entry into the eye can create unfavorable points of chronic mechanical trauma by the eyelid and lead to late tube exposure. This is often observed with anterior insertion of the tube at or close to the limbal area. Now, creating the tube entry 1 to 2 mm posterior to the limbus with a tunneled track can decrease exposure complications. Entering the eye superiorly, closer to the 12 o'clock position, can also decrease direct pressure on the lid margin on the tube shunt, preventing chronic conjunctival trauma and atrophy. Hence, using a patch graft during the primary tube plantation or tunneling the tube through the sclera for at least 5 mm is critical to decrease in the risk of erosion by preventing the direct contact between the tube and the overlying conjunctiva. Now, we know about the multiple patch grafts that are available, which include the pericardium, the sclera, cornea, amniotic membrane, and biodegradable porcine-derived collagen matrix. Most commonly, in such cases, we use the scleral patch graft. In such cases, an urgent surgical intervention is indicated. Typically, the conjunctiva surrounding the exposure is friable and tenuous. So we need to achieve a tension-free closure at the limbus. Cauterization of any epithelial ingrowth around the tube may promote proper healing and minimize the recurrent exposure. Hence, the tube can be positioned posterior to the limbus or may insert the tube in the pars plana area. This is my own case. The tube was exposed after 9 years after the Emmett valve implantation. As you can see by the arrows indicated, there is fluorescent staining there. The tube exposure is around 1 mm to 2 mm. The patient is from out of country, hence he's going to come back for a scalar patch graft later. And this is one of the archived photographs from the net where we can see the inferiorly placed valve is exposed. Thank you so much for your patient hearing.
Thank you, Shudipta. That's a nice talk. My question to Manish is, which is the favored graft you use for covering the...
We have the access to scleral graft, so we use mainly sclera. Another good option is if you have access to cornea, that can also be used.
So, what is the durability here? It's better with cornea or scleral patch?
Both of them are very good. Cosmetically, cornea is better, but availability of sclera is better, so mostly we will use sclera only.
Does anyone uses MMC while using graft? I mean, while using implant?
In certain cases of high-risk failure, patient who had a history of, say, hypertensive phase, prolonged hypertensive phase in other eye, we have tried MMCs. But we had a few cases of plate exposure after MMC, and there are some documents that MMC reduces your healing. So we then discontinued using it.
And Dipanjan, you want to comment anything else?
Now there are various other ways of doing it. I think there is a paper from Arvind Eye Hospital by Dr. George, who has proven that putting, like she also has mentioned in her talk, that is a long scleral tunneling, that is at least 4.5 millimeter. It's good enough and you do not have to have a scleral patch graft. And now in these days, we are not enucleating. So mostly availability of the sclera has been an issue now. So we get corneas because we are doing DMEC, and the most of the upper part of the cornea is available for you, the stroma and the epithelium part. But the tunneling is an excellent thing that you can easily do. Another recent thing is that there is the patch is available from the same people who supplies KDB and Ahmed glaucoma valve now. They have come up with some membrane, it is derived from the umbilical cord. So I am just waiting to use. I have got one sample from the company, but we do not know. It is something they are claiming to be proven to be better than scleral patch graft, because it will give a more cosmetic thing actually. Yeah.
Yeah, but I feel that even when you are using a long tunnel of about 5 millimeters, it is perhaps on the safer side to put a patch on top of that. And basically, of course, as Manish has said, the corneal graft, if you can put it, is cosmetically more acceptable. But you can do a lamellar dissection of the sclera and put a thinner patch graft in that case. But I don't think that, unless and until you have a long series like George has, you will be brave enough to just leave it at the tunneling.
I don't use scleral graft regularly because of non-availability. I usually do scleral flap. When you are using doing scleral flap, you should remember that the flap should be at least half the thickness of the sclera. It should be a large one, at least 6 millimeter. And
Do any of you have tube exposure cases?
I had 2.
How long back? How many years post-op?
One, in my case, it was, the first case was maybe few weeks post-op.
Acha.
Probably it was due to poor suturing.
Ah,
You have to be very careful about the suturing. And the second case was years after. Right? And
1 millimeter tube exposure also needs closure.
yes, definitely.
Any
point,
any measurement you should cover it, right?
Even a point exposure also, that becomes the area for infection to develop. And we had a patient who had come from Bhutan when we were in Shankar Netralaya, and the pressure was controlled, but the blood sugar was high. So patient slightly delayed the surgery, and we ended up in endophthalmitis. So tube exposure should be treated as an emergency. The earlier you intervene is better. And we had multiple cases of tube exposure. Obviously, one of the reasons which Neela sir was telling is the suturing is not good. So tube is a plastic thing. It has a tendency to straighten up. So when it is trying to straighten up, your sclera or the patch graft is preventing it from straightening up. So mechanical thing is one of the major reason. But we had a patient who was a diabetic patient. He was a doctor, and we had a tube exposure after 1.5 months. We did a repeat graft. We again had a tube exposure after 1.5 months. Third time we did it, and third time also we had. So we realized patient was actually having an immunological problem. The graft was melting. So next time what we did, we created a tunnel, 5 millimeter, and just put it directly over the tunnel, and the tube survived. So very rarely you can have an immunological mechanism where the body will reject the graft and the graft will melt. So if you are having a recurrent tube exposure erosion and the graft is melting, then you should think of immunological causes also.
Another thing is, as one of the mechanical parts is different patients have different dynamics with the lead going continuously over the graft. So that varies from patient to patient, and there are rare patients in whom the lead movement is so tight and the continuous friction over years actually leads to the dissolution of the cover.
Throughout their life.
So instead,
Yeah, the
what
second can
about
be
if we like use the conjunctiva to cover that small gap, or
You
does he
can.
actually need a sclera?
No, if it is a, no, if it is
Will
a,
melt.
if it is like,
To mobilize the conjunctiva,
Huh.
maybe you can put a small scleral patch graft and cover it with an amniotic membrane.
I have already made a scleral tunnel in this one.
I have a patient who was 8 years or 9 years ago, and he had a tube exposure, and the scleral patch was in place. I took conjunctiva from that same eye, from the inferior, and put it up there. And the patient is still, the bleb has gone slightly flat, but the patient is still doing well for 9 years about.
mostly if it is a perilimbal conjunctival hole kind of a thing, it is usually because of avascularity in that area. It is getting necrosed. It is basically an avascularity of that area. So what you can do is you can even take a fornical graft which gives the blood supply, like it takes its like a pedicular muscle flap.
Correct.
Okay, it is also explained very like that there are already studies on that. You can definitely take a graft from the inferior conjunctiva, but there can be again an avascularity issue because there is no attachment. So that's an issue.
That's a nice tip, actually.
Okay, thank you so much,
Thank you.
everybody.
Huh.
So our next speaker, Dr. Chandni Chakraborty, senior glaucoma consultant in Panvision Eye Clinic, and she'll be talk on the childhood glaucoma.
A very good morning to my learned colleagues. At the start of my presentation, a disclaimer: I am not a glaucoma person. I am a pediatric ophthalmologist and screen surgeon. So pediatric glaucoma, though it is not very common, but in terms of blind ears, it may cause significant visual impairment burden to our society. I have no financial interest in this presentation, so there are some challenges in the management of childhood glaucoma. There are so many terminology and classifications about childhood glaucoma. I am not going into details because of lack of time. So the most modern classification is the CGRN classification. They have defined childhood glaucoma and childhood glaucoma suspect in very precise way. Now I am coming to the practical points. We can divide the clinical presentation of the childhood glaucoma patients into onset before 3 years and onset after 3 years. And onset before 3 years are very dramatic. There would be epiphora, photophobia, and there are dramatic anterior segment changes like enlargement of the globe. Then you can see the half stria in the decimus membrane. Then extensive scarring of the cornea. And these changes are most common in case of older children. And in case of developmental or congenital glaucoma, angle changes are very common, and you have to do the gonioscopy. Then there are some associated anomalies which may cause glaucoma. There are secondary glaucomas after cataract surgery, after long-term steroid use, and after trauma. And also secondary glaucoma may occur in neoplastic conditions. So this is the CGRN glaucoma classification system. Now the workup, what is defined from the adult is we have to measure the corneal diameters very precisely, then retinoscopy and progressive, that is longitudinal follow-up of the axial length as there is progressive myopia in glaucoma patients, and photographic documentation of the fundus photo is very important. So these are the armamentarium for glaucoma assessment. And these are the IOP, normal IOP for different age groups. These are the corneal diameter changes with age and suspicious cases where we can suspect glaucoma. Then this is the axial length changes. Now the workup in older children may allow office examination, but for the younger children, EUA is must. These are the different steps of EUA. You can see the Perkins tonometry should be done first because there may be some changes in the intraocular pressure measurement after anesthesia. These are the anesthetic agents which may modify your intraocular pressure measurement. Now the other investigations are OCT, HFA and all, which are though not age matched for the younger children, but for 12 years and up, you can do this multimodality investigations and longitudinal follow-up, which may help you immensely. So the medical management is with topical carbonic anhydrase inhibitors, beta blockers or prostaglandin analogs. Now the surgical management, surgical management is not always satisfactory, but these are some of the surgical modalities, that is TAB with MMC in older children in the upper video, and combined trabeculotomy and trabeculectomy in younger children with congenital or infantile glaucoma. Generally, we do not get the scope to do goniotomy here because most of the patients come with their cloudy cornea. So the take-home messages are systematic approach to diagnosis, individualized management, and adequate management of the secondary complications which are unique to children, like corneal opacification, refractive error, and amblyopia management are very important. And lastly, but not the least, lifelong follow-up is very important in case of childhood glaucoma. Thanks for your patient hearing.
Thank you, Chandni. It's a huge topic and you summarized it in just 3 minutes. Dr. Alokesh, do you want to comment?
Yeah, I think right now there are different modalities which are also being investigated as to doing a 360-degree goniotomy along with the trab. So anybody is having any experience with that here?
Combined 360-degree goniotomy with trab. In childhood glaucoma. Do you do? You do?
Yes, sir.
So please tell now.
Sir, I have already done 3 cases of GAT, but 360.
Loud.
3 cases of GAT, but that is not a 360 degree, 180 degree GAT with an 50 prolin. So 360 degree, the 180 degree is much more better because in 360 degree, there is a destruction of the angle anatomy structure. So 180 degree is better than the 360 degree.
So that she actually keeps the rest of the trabecular meshwork for future, like all the drugs, like we know Rho kinase inhibitors and all the many of the drugs probably in the pipeline, we were going to act through that. So why keeping the patient without any trabecular meshwork for the rest of his life. That is the thing, no? Yeah.
Maybe in the same sitting, like trabeculectomy and...
Trabeculectomy. This is an
it's only
GAT.
GAT. Oh, it's only GAT.
Yeah.
Okay. And the pressure control was?
There's a nice pressure.
Yeah. And like what was the drug you gave after doing GAT?
After doing GAT, you can prefer the prostaglandin analogs you can use. Because before surgery, there is no role of prostaglandin analogs. Before surgery, the prostaglandin analogs have no role. Because there is a main problem or pathology behind the trabecular dysgenesis, that is the angle. So after surgery, you can use the prostaglandin analogs. Yeah. And dorzolamide.
And what is the age of the patient you did?
2 years.
2 years. Okay.
I have started doing in cases where the visibility permits. After consulting Shushmita, I have started doing bang in a couple of cases, but primarily I still depend on trab and trab, which I've been doing for years, and where I am seeing that there is visibility. But I've just done a couple of cases, so I will not.
And the goniotomy has an excellent result.
Yeah, but one point is this, initially why I asked it, because Dr. Anil Mandal sir had shown us that with a laser emitting goniotomy, Anil Mandal sir has I think published, he's on the verge of publishing that in congenital. It's a LED guided 360 degree laser guided combined with the trabecle. Now the point is this, that in many angle closure glaucomas, and specifically in congenital glaucoma, the site of the dysgenesis may be beyond the trabecular meshwork. So there, how much it will work is speculative.
So that is the thing. That is why Dr. Mondol is doing the two things at one point of time. Like we know that the most of the time there is a 50% chance that your level of resistance is biotrabecular meshwork, probably in the collector channels and things. So what he is doing is, what you are talking about, it is ab internal procedure. He is doing an ab external procedure. So he is making a large flap, and then he is basically threading through the Schlemm's canal, and then it's a 360 degree, and then he is from ab external, he is tearing the whole 360 degree and also combining it with a trabeculectomy.
That is very important, because one thing I remember, Satyan sir always used to say that when you do for a child, you have to do the trabeculectomy fine, but your trabeculectomy is the one which you do with the utmost diligence, because you never know which works.
Yeah.
Nothing that this is primary and that is secondary. Both are of equal weightage. So you have to ensure that at least one works. So the combined procedures in the child has got, I think, that advantage.
That is one part of the story. I think we also should discuss that when we operate or see the patient, and how would you like to follow up? What are the parameters we should follow?
That's more important, actually. That's very important.
We follow the approach like first 6 months, if the patient presents, we do a simple trabeculotomy. After 6 months and patient who present late with corneal diameter 14 or more, we do a combined surgery. In case after surgery, after 1 month, we do a repeat evaluation and anesthesia. If the pressures are fine, a repeat evaluation after 3 months. If the pressure increases, the preferred drug is dorzolamide and timolol. Prostaglandin, I'm not very sure whether we have enough literature on that. If we see the surgery has started to fail, then a goniotomy has now come in as a procedure, because anyway trabeculotomy is done superiorly, so inferior angle can be. This is the current approach. If the baby is slightly elder and even 2 surgeries have failed, then even shunts also we have done in cases.
And in the follow-ups, only not the IOP, but also the axial length and the corneal diameter.
So axial length is an indicator.
Yeah, there are 3 things.
And the diffraction. We have to save the child from developing amblyopia. Yeah.
So that is a main management.
And we have to have a management where we have both the glaucoma doctor and a pediatric ophthalmologist, and also preferably a cornea doctor, so we can work as a team.
Yeah.
Because amblyopia management is as important as IOP control in pediatric glaucoma.
So the management of the pediatric glaucoma is a multidisciplinary approach that includes the glaucoma consultant, cornea consultant, and pediatric ophthalmologist.
Can I ask to Dr. Manish one thing? that is, what is the failure rate after combined TREB and TREB?
So if you want to see published literature, what Dr. Manin Mandal sir has said,
in your
his
cases,
failure
I am
rate is,
asking.
say, he get almost 80 to 90% success. In our cases, we have got around 60 to 70%. But that depends a lot on the stage of presentation.
Yeah, actually,
One
I
big
have done
problem
very
is the
less number of
follow-up.
cases. Yeah.
Follow-up is a very big
Follow-up
problem.
is very important. Lifelong follow-up is very important.
Most patients don't follow up, and if their patients are outstation and all, it's very difficult to follow up.
That Manish is saying, asking the parents to
Yeah.
follow up.
Yeah.
And also, to do the UAs, one after 1 month, one after 3 months, and one after 6 months is almost impossible.
It is very difficult, yeah. For practically, I am also finding this problem. Cost is a problem.
Okay, thank you,
Thank
Chandni.
you.
We'll move on to the next speaker, Dr. Gitanjali Sharma Bose. She works in Nayanjyoti Eye Center in North Kolkata.
A very good morning to all. Thank you, Dr. Swati ma'am, for the opportunity. So, what are the determinants of glaucoma management whenever we face a patient? First is the type of glaucoma, the severity. This is the severity classification. The progression, it is very important. I'll talk about this in a bit. Very important to know when not to treat a patient of glaucoma. Any patient over the IOP of 24 does not require treatment. The medical therapy, whether you want to switch or whether you want to add, and the follow-up. Now, this is a whom to treat graph. So line A represents the effect of aging alone. So it is a very slow, gradual loss of axons over years. Line B and C are what we are seeing just now. Both have the same rate of progression, but as you can see, C has a very early onset and therefore has a risk of severe functional impairment and therefore needs more aggressive management. Now compare D and E. Both had the same age of onset, but E had a very steep rate of progression and therefore needs a considerably lower target pressure. So what are the factors that should be considered when we set a target IOP? Patients with advanced glaucomatous damage, young age, low untreated IOP, those with additional risk factors such as low CCT, and with a fast rate of progression must be set at a lower target pressure. Amongst these factors, the severity of glaucomatous damage and the rate of progression are the most important factors. So these are the medical therapy options. I'm not going into that. So we decide the target IOP for each patient and each eye individually. These are the American Academy guidelines, 20, 30 and 40% for mild, moderate and advanced glaucoma. Now it has been found that there are some patients who continue to progress despite IOP control, despite them meeting their target IOPs, and here comes the role of the rate of visual field loss. So the European Glaucoma Society recommends 3 field tests per year for the first 2 years after diagnosis. And on the basis of this, we classify the patients into slow, rapid and catastrophic progressors. We see the rate of mean deviation loss. If it is less than 1 decibel loss per year, it is slow, 1 to 2 is rapid, and more than 2, these are catastrophic progressors and we have to be very aggressive with their management. Other than these, other than the IOP, other than the rate of progression, we should also keep into account if there is a history of nocturnal hypotension, any systemic disorder such as uncontrolled diabetes. Sleep apnea is often ignored. And this is the flowchart, how we decide whether you want to switch or whether we want to add. If the therapy is not tolerated and if it is not effective on IOP, we would like to switch it. If still the target IOP is not reached, then we will like to add the medication. So in the end, target IOP, it is a dynamic phenomena. It needs to be revised from time to time. Greater initial field loss is the most important predictor of blindness. We need to manage expectations. And in the end, not a single patient of glaucoma should go untreated. Thank you.
Thank you, Dr. Gitanjali. Niloida, your comment on this.
Comment on target intraocular pressure? Yes. That is the initial goal of medical management of glaucoma, whatever management of glaucoma is there. And there are 6 different protocols for that, depending on the severity of the disease and the initial baseline intraocular pressure. So the main thing you should remember is it is the initial goal, not the final goal. It is a dynamic one, and it is a range, and you should never mention it maybe to the patient also. This is your target intraocular pressure we are going to achieve. Keep it in your mind and try to achieve it with minimum medication, with minimum doses, and the cheapest maybe.
Thank you, Nilada. Does anyone of you follow GPA and target your treatment?
If it is definitely of great help if we can use GPA, but unfortunately in a high volume hospital like ours, it is very difficult to be able to place the patient in the same machine. So this is one thing that we are actually not being able to use.
One of our branches we do it because there we have a control of number of patients that we are seeing. So definitely GPA is of great help. Basically, actually if you see from practical point of view, most of the time you need GPA for two things. One is for research and another is for actually to show the patient that this is your position and you should not get worried, or this is your position, you should get worried, you need a trabeculectomy. For all practical purposes, for your day-to-day glaucoma management, you might not have GPA until you can manage. That's what I feel.
We tend to follow the GPA quite actively, most of the cases. But then another thing is this, that if you really see that the GPA is showing progression, then you have to take out that time to individually see the, the previous fields, all the printouts, and see whether really what the GPA is showing. In many cases there are marginal progressions which you have to analyze yourself. Take time out and do it. But that is again, as Dipanjan said, sometimes very difficult in a rash OPD. That's a problem. But ideally it should be done, I believe.
Yeah, but one is what Alokesh is saying about early progression. But I have in GPA, some of our few patients who have managed to hit the same machine, once it was appointed to me in that heavy clinic that it was a rapid progressor. So that again, sometimes we miss it. Even we shouldn't, but we do, that it is a rapid progressor. But when you see that curve, then it gives you a jolt that I need to do things differently now.
Sir, any role of OCT in advanced glaucoma management? Any role?
One point regarding GPA.
I don't believe there is much of a role at all. Manish?
First point regarding GPA, as Sujandadi was mentioning, if you have 2-3 machines, then you have to put the patient on the same machine. That becomes difficult in a busy practice. But there is an option in Forum that if you can connect the 3 machines through Forum software, then it can be done. But then there also sometimes there is an issue. But if you can use GPA, it's definitely a help. And regarding using OCT for advanced glaucoma, the problem is after a stage there is a flooring effect in OCT. So I think it's not very cost effective. It's better for the early glaucomas.
You can use the GC IPL part if you want to, even after flooring effect. Not much standardized.
My question to Dr.
How
KP
much of the
Ghosh,
change is significant? That also is not standardized.
If you don't have GPA, VFI is also probably a good indicator. If VFI and the worsening, if they show a definite trend towards going down, then probably it is worsening, if all the results are reliable.
Yeah. GPA also gives that VFI plot, which is very useful.
my one practical question to Dr. KP Ghosh, sir. Sir, when a person is not responding with 2 drugs maybe, so do you prefer to add another 3rd drug, or do you want to switch to any other molecule?
No, regarding prostaglandin, if it doesn't work, then I switch to other prostaglandin. But regarding other drugs, no problem. If it two doesn't work, we work for go for 3. If 3 doesn't work, then we plan for surgery.
So everybody agrees with that? Dr. Yasin sir, would you comment?
Yes, I think I agree with him, because it is said that prostaglandin analogs, if one doesn't work, maybe change of brand will help. So I think it's a good idea to change the brand. And other ones, I think if they do not work, it's better to add another. That's it.
Thank you, sir.
So our next speaker, Dr. Pallavi Raj, the Senior Glaucoma Consultant in Ikshana Eye Care.
Yeah, just to add one thing, that how we should define the non-responder of a prostaglandin. There is at least 3 weeks of constant medication. Even if we do not get at least 10 to 12% reduction from the baseline intraocular pressure, we call it a non-responder. So before changing to another drug where the patient has already paid for it, so we please have a little patience until unless the patient has a very high intraocular pressure or very advanced damage. So that time is to be given for the prostaglandin to really act.
No, it happens, no? Like over the years, the patient is not responding to the same things. So that time you have to change. At the beginning of the treatment, yes. And how long do you think we should wait for that? Prostaglandin, right. Yeah, please.
So I'm going to present on a rarest complication of a rare glaucoma drainage device. A 37-year-old male patient presented to me with a history of right eye redness, pain, watering for a month's duration. And on examination, I saw that there was an extruded tube. There was a sealed corneal perforation, iris was incarcerated in it, there was irregular AC, it was an adherent glaucoma. There was a superior PI and there was an occlusio pupillic, because of which I could not see the posterior segment. Now the plate of this device was totally covered with mucopurulent secretions, and I also saw it being sucked inside the tube. So this is a closer picture of this case. So I went ahead with exploration in this patient and made a video pre-operatively. Here we can see how at the start of surgery, how the extruded device, that is the tube, is having a windshield wiper effect on the cornea, on the surface of the patient's eye. And I could also see the ethibond sutures of previous scleral buccal surgery. Patient had history of 2 intraocular surgeries 12 years back. So I started the exploration in the supratemporal quadrant in the right eye and tried to pull out the tube, but it was not happening. So I put a superior rectus suture to gain a better exposure, but still I was not able to pull out the device. On doing this, I also noted there was a scleral perforation and there was vitreous prolapse, and I was confused whether it was a belt. But I thought that I should try hard, and so I continued with the exploration and tried to remove the device, and finally I was able to free the lateral edge of the device. There also I noted there was more scleral perforation and there was also vitreous prolapse. So here we can see the vitreous prolapse, but the medial edge of the plate was stuck, and that was because of the fibrosis through the holes of the plate, and that I had to cut through it, and then finally, lo and behold, what did I see? It was a Barwelt implant. This implant is very uncommon in Indian scenario. This valve is not available. This device is not available in India. So I went ahead with suturing of the perforation. I did a perforation repair. Generally, the extrusion of the Barwelt implant is not described in adults, but it was seen in this patient. It is commonly seen in the pediatric population because of the eye growth. So then I formed the AC. I put in visco in the AC, and I realized that there was no corneal tear. The perforation was perfectly sealed. So the case was given to the VR surgeon, who put in the ports and noted some extra leakage from the scleral perforation, and went ahead and completed the scleral repair. Then he tried to gain the view of fundus by retracting the iris, but the iris was completely plastered to the lens, so he had to create a new pupil with the help of a vitrector. So after creating the new pupil, then he proceeded with pars plana lensectomy. The lens was removed from the vitreous, and he also noted that there were no signs of endophthalmitis in this patient. Finally, we sutured the wound, and final steps of watertight closure were done, and it was a good closure, and the site and the ports of the VR was also closed. So at the end of the surgery, ocular surface and cosmesis was restored, and here we can see the post-op picture of this patient with a new pupil and the extruded tube removed completely, and also compare it with the pre-op picture. Thank you for your kind attention.
Thank you, Pallavi. That was a very nice surgery, and a VR surgeon husband always comes in handy in such cases. Okay, so one more complications of aqueous drainage device. Any comments?
It seems like a very neglected case of tube exposure. Maybe the patient over time didn't had a good visual potential. That is why over time tube came out. And patient must be having foreign body sensation, and also it doesn't come out whole of it in one go. Must have been slowly coming out. But patient was lucky not to have an infection.
Yeah, the history was of 1 month duration.
Patient was lucky not to have an infection, and so much of scleral problem might be having some other issues with scleritis also, which we may need to explore whether the patient, why there was so much of scleral thinning. So that part also probably we need to investigate in this patient, but it was nicely managed.
Where did the patient get operated?
SN. 12 years back at SN.
So Barville must have been a sample.
Yeah, I asked him. He told me that his device was imported from Germany 12 years back, and it was done free of cost.
And at that point, he had secondary glaucoma from uveitis, or he also had some injury, etc. history?
No, he did not give a history of injury. He just said that he had undergone this device implantation, and he had a history of RT surgery. And then he said his vision had been mostly poor and not much symptoms, but for the past 1 month he said that there were more symptoms.
So what was the optic nerve head status?
That was secondary, full glaucomatous optic atrophy. He did gain some vision. He was PR inaccurate, and then he became CF after the removing the lens. He became CF. Yes, the IOP stabilized on 1 AGM after the surgery.
Okay, that's good.
So basically there was a scleral buckle in place.
Yes.
And the glaucoma was a secondary glaucoma
Yes,
after the surgery.
Glaucoma, yes.
So the Barville was implanted beyond the buckle.
Yes.
Sometimes actually if the buckle, sometimes they put the buckle.
We realized it must have been much posterior compared to the device, this Barville.
Okay,
Because
the device was anterior.
Yeah, when I was dissecting, I thought that maybe it is the buckle, but then we realized that it must be much posterior, because I was finally able to explant it.
And the buckle was there?
I did not explore so much, but he had a history of buckling surgery.
I have a question for Manish. What if we just cut the wings and keep it there and take the central part of the thing out with the tube? And if we do not mess with the portion that is actually buried behind the muscle, like underneath the muscle, and probably because they have put a buckle and that area of the sclera is extremely thin. So if you want to pull it out with the fibrosis and all, there is always a chance of vitreous leakage. So if we just make a cut and keep those wings, like lateral wings there inside, would it make a difference?
No, actually the plate was
my
totally
question,
covered
Manish, have you tried it? Like,
no, not eroding. It was totally covered with mucopurulin secretions. That is why we had suspected an end-off. So that's why we wanted to remove it totally.
Okay.
Is this a young patient?
He was 37 years old.
And he had a RD surgery
12 years back. And this device surgery 12 years back.
This was done in Shankaracharya, Calcutta?
Yes.
So this was not a Barville. This was a RD surgery, which was done by me actually. This was the first RD surgery we did in Calcutta.
No, but he told that the valve was imported from Germany. He told me that.
Patient can say anything. So this was the first RD sample which was given by Arvind Hospital.
No, you were not the surgeon. I saw the notes. You were not the surgeon.
that Monisha said the patient that I will just give you something which is imported from Germany. So he told this.
In SM Calcutta, at least I can tell you, Barwell was never done. It can't be a Barwell.
No, Manish, when you have told that the patient believed, if me or Dipanjan said, the patient wouldn't have believed.
See, I might have told, what patient understood, because this patient was lost to follow. So I am also seeing after 12 years.
No, you were not the surgeon. I saw the notes. He was not the surgeon.
Remember why? Because this was, I tell you why this is important, because, no, I tell you what, this was the time when the RD was launched and Dr. George has given some samples to some doctor, and this was the first RD we did in East India probably, and there was a case of post-buccal. So everything is matching. So now I can realize this is the same patient, but unfortunately after 1.5 months the patient never came back for follow.
Yes, he was poor.
So that is very important. The patient must be having problem. He never came for follow.
No, but you were not the surgeon. I saw the surgery notes.
It's not a Barwell. It's not a Barwell. It has to be RD only.
That is 12 years back.
Okay,
There is a larger
10 around, 10, 11. That time RD was launched.
Because in 2012, George showed me a video in Coimbatore GSI. George showed us the video.
Like gave us some samples to use.
It was 2012 Coimbatore that George showed us.
by the time Tanya prepares a slide, can we discuss something about the ROC inhibitors? The ROC. Okay. As first line of management, second line, third line?
Second and third. Second or third. In some cases.
One more thing, I think the scleral melting can also be because of the buccal.
Yeah. That's what I was
It could not be because of the implant.
Only I have read once in somewhere long back that they had put the buccal on top of the valve, and that mechanical pressure eroded through. Some case report somewhere I have read that.
Okay, Shuparnadi, do you use Netalo eye drop?
No, means I'm frightened to use them because I have heard from stalwarts who started that it gives so much irritation and so much redness that patient comes to the doctor and asks them to take it off. This was many years back, but from then on I used it.
Okay. So you think Ripasudil is more patient friendly than? Okay. You don't? The Netasudil eye drop, do you use? Okay. Anybody who uses?
Find that much of Oh, no, at least you put one time. So naturally, when you go for Netasudil, you have other glaucoma drops too. So if you can reduce the number of drops, compliance is better. But I don't find that much of irritation with Netasudil as Ipasudil is also I use. Ipasudil is now almost used like Avastin. Corneal edema, you put Ipasudil. Yeah, 3 times.
And do you have any corneal microbully or corneal edema comes back once again with Ripasudil? Okay. So, Tanya, is it okay?
So good morning everybody. Today my topic on an emerging role of Rho kinase inhibitor in glaucoma management. So all of you know that the glaucoma is a leading cause of irreversible blindness globally. 12 million people affected, among them the 1.2 million people blind from the disease, and more than 90% of cases remain undiagnosed. So the management of the IOP lowering medications, there are 4 classes of the topical ocular hypertensive agent that are most commonly used for the long-term therapy, that including the prostaglandin analogs, beta-adrenergic blocker, alpha-adrenergic agonist, and the carbonic anhydrase inhibitor. So the drawback, none of the current available medication addresses the underlying pathology. Beta-adrenergic antagonist do not lower the IOP during the nocturnal period, and the many patients are unable to tolerate one or more of this agent, and even all the 4 agents are used in combination, IOP lowering can be insufficient. So the need of the hour is an agent with a novel mechanism of action that directed towards the lowering the outflow resistance, highly effective during both the diurnal and the nocturnal periods, preferably with an additional pharmacological properties that support the retinal function, and the well tolerated with a minimal adverse effects. Now come to the Rho kinase. Rho kinase are the small GTP binding proteins, and that has begun in the late 90s and continue to be present time, and the ROC signal pathway involved in the several cellular events. So the Rho kinase are widely expressed in the ocular tissue like in trabecular meshwork, ciliary muscles, iris, and the retina, and they have been implicated in the pathology of the many ocular conditions like in corneal dysfunction, glaucoma, cataract, diabetic retinopathy, age-related macular degeneration, and the retinal detachments. So the ROC inhibitor role in glaucoma that decreases the aqueous outflow resistance, neuroprotections of the retinal ganglionic cells, and increases the ocular blood flow. So it decreases the aqueous outflow resistance by altering the cellular component of the trabecular meshworks and the Slem's canal, and it has also the neuroprotection ability to enhances the axonal regenerations and also increases the ocular blood flow by causing smooth muscles relaxation leading to the vasodilatations. So the ROC inhibitor potential to reduce the scarring after the glaucoma surgery by the anti-scarring agents, by the inhibition of the transdifferentiation of the tenon fibroblast into the myofibroblast, and it also preserves the corneal endothelium. So the most commonly Rho kinase inhibitor is used in the ripasudil and the netasudil. So these are the clinical evidences. So in ripasudil, the maximum IOP reduction within the 2 years is -7.3. And this is an 1-year clinical evaluation. This is the safety of these drugs, and that is an acceptable safety profile. An additional side effect, the neuroprotections, increases ocular blood flow, reduce the scarring after glaucoma surgery, preserve the corneal endothelium, and the protective effect in diabetic retinopathy and macular edema. So the uses of ripasudil for the rapid resolution of the hydrops in the keratoconus, this is unpublished. And the effect on the corneal wound healing. So ripasudil promoted the corneal endothelial wound healing, supporting its development as an eye drops for treating acute corneal endothelial damage due to the eye surgeries, especially after the cataract surgery. So now come to the contraindication. That is, if the patient have an hypersensitivity to the active substance. Adverse effect, the most common adverse effect is an conjunctival hyperemia. The dosage is on 1 drop 2 times a day. Now come to the netasudil. The netasudil has an additional advantage, that is, it reduces the episcleral venous pressure. So the netasudil increases the trabecular outflow by 35% and decreases episcleral venous pressure by 20%. So these are the clinical evidences that published in the Journal of Glaucoma 2022. And here, the once daily netasudil was a non-inferior to the twice daily timolol, and the IOP decreases from the baseline was in 3.7 to the 4.8 compared to the timolol, where the IOP reduction 4 to 5.3. So and netasudil had also the acceptable safety profile, and the most common adverse effects on conjunctival hyperemia. An additional benefit like that, the ripasudil neuroprotection increases the ocular blood flow and reduces the scarring after glaucoma surgery, preserve the corneal endothelium, and the protective in diabetic retinopathy and the macular edema. So now come to the doses. Doses is the 1 drop in the affected eye once daily in the evening. So hence the ripasudil have a potential to fulfill the need of the hours, target the disease pathology, maximal IOP reduction within the 2 hours, effective day and the night IOP control, effective as a monotherapy and the combination therapy, sustain effect up to 52 weeks, and effective in patient not responding to the maximal therapies and appropriate medication for the inflammation associated with an OHT, and additional beneficial pharmacological properties and acceptable safety profile. So, thank you.
Thank you, Tani. In the interest of time, we'll just end the session here. I'll ask Shuchanda to just summarize.
And excellently, all speakers have actually put forward very important points and with crisp presentations. So the take-home message, I think, for all of us stands that we need to customize each and every patient depending upon the age of the patient, the life expectancy of the patient, the grade of the glaucoma, the severity of the glaucoma, and age of presentation of the glaucoma, the IOP at the initial presentation, and very, very importantly in our country, the affordability of the drugs, which is absolutely a key point to maintain adherence and persistence from the part of the patient. And in that aspect, I think Ajanta has been helping us greatly by bringing a lot of drugs, making them highly affordable for the patients, and also giving us a scope to be able to use these drugs and understand and help a lot of patients and give them more sight years.
Thank you. I'll call all of the panelists and chairperson and the speakers to please come here for a group photograph.
এই দেখুন আমি নিয়েছি এই ডিবেটেবল নিইনি কিন্তু এটা খুলছে